Welcome
Sure.
everyone to market-based approaches to finding value in healthcare, keeping healthcare affordable and accessible to patients. We're delighted to have a guest today on today's show. His name is Sean DiGiovanna, and Sean is someone that I've worked with in the past, and I'm delighted to have him. Welcome to the show.
Thank you, Kent. Glad to be here.
I wonder if you might start by giving us a little background on your work journey and what some of your interests are around our topic today, which is evaluating social determinants of health in healthcare.
Sure, Kent. I'm happy to do that. I started off as an economic geographer. That's my training. Went to school, did a PhD at the University of Toronto. And my focus was really on community economic development and industrial policy, and really concerned with inequities in the distribution of resources, as it was for jobs mostly, right? And so even though I'm now in the healthcare space and I don't have a huge background in healthcare, there's a lot of very similar factors at work in terms of access for people trying to get those resources. But in terms of my professional journey, so I started off in academia at Rutgers University. I was there for 10 years, really doing a lot of research for local municipalities in New Jersey and also community groups and organizations. I did a huge study for the Pew Research Center on Solutions for America, it was called, on community organizations and the things that they do that are successful. So that really piqued my interest in community-centered economic development. And then I transitioned into high school teaching for a while, still doing some of my academic work and some of my publishing, and then became a consultant a few years back when the pandemic hit. And now I'm working as the head of research for Gettysburg Healthcare Consulting.
So I wanted to probe just a little bit more on something that you just said pertaining to your academic background, particularly around social determinants of health. I think you had mentioned that there's not a formal training program per se in healthcare. I wonder if you might expand how scalable healthcare is across just the general matrix of social determinants and access related issues to other things like groceries or pharmacies or other similar types of things.
Sure. And, I guess my belief and what I've always kind of taken as my North Star is this idea that all these things are interrelated, and you can't have a healthy community. And that means not just healthcare, but that means also jobs. It means family stability. It means built environment that's conducive to a good experience for children growing up, education. All those things are related. And so it's hard to tease out one from the other. But what I do know is that we always see worse healthcare outcomes in areas where there's poverty. It's really a question of trying to, in the best of the kind of Gilded Age, progressive era movement, really try to help people by educating them about how to better help themselves. But really, it's a lot more complex than that. And when we're talking about, let's just talk about the built environment. So, for example, Baltimore has a huge number of abandoned properties, right? So, and these are obviously concentrated in poorer areas. So what do you have in these abandoned properties? Well, you have lead paint, you have a lot of particulates, which lead to increased cases of asthma. You have a lot of them being used, potentially as drug dens or other types of informal spaces. You have children playing in them. So, an abandoned building is not a child's playground. And of course, there's going to be healthcare consequences for things like that.
I want to probe a little bit more detail on what you just said about Baltimore. It's my opinion that we have a public health crisis in Baltimore. And let me explain what I mean by that.
Sure.
In the city of Baltimore, is just like many cities and large urban areas around the country, the city is defined by smaller communities, which tend to be homogenous in terms of where people reside and where they continue to reside throughout their lives. So there's not a lot of per se migration, inner city migration amongst the different zip codes that live, the different zip codes within Baltimore City. And what I've noticed and have noticed over the last several decades is this life expectancy discrepancy. And you could look at any one of 100 different social determinants of health statistics. I just chose life expectancy because perhaps it's the most poignant and the most important when we think about public health and trying to prolong life years and even quality of life. In Baltimore City, depending on what zip code you live in and are born into, you have a life expectancy of anywhere from 65 to 66 years on the low end, up to the high end of 84 years of life expectancy. So if you look at Baltimore City as a system of interconnected zip codes, depending on which zip code or which interconnected smaller area within the city you belong to, that has a dramatic impact on your life expectancy. In this case, I'm not a mathematician here, but 66 to the discrepancy is 66 years to 84 years. So we're talking about an 18-year life expectancy difference. Think about that in terms of everything that you could accomplish in 18 years.
Right.
Depending on where you live in the city, that is taken away from you, or it's given to you in other life years, depending on where you live within the city. So I'm fascinated with your background, and what I'm trying to do is identify why certain areas of the city have a life expectancy of Pakistan, which is obviously a third world country in the Middle East, while other areas of the city enjoy a life expectancy in excess of, let's say, Japan, which has the highest life expectancy of any country in the world. And they're, generally speaking, no more than 2 to 3 miles apart from each other. Some zip codes abut each other. And so when we look at different characteristics or social determinants, I'm very curious as to what is driving that life expectancy difference. What do you think's going on here?
But it's a very complex question, but there's a lot that goes into it. And I'll just start by saying, as an alumni from Johns Hopkins, having lived in the city and seen firsthand the discrepancies between neighborhoods that are bordering each other in terms of just resources and quality of life and income levels, all of that is part of the problem for sure. So I think really the way I was thinking about it when we kind of talked about talking today was thinking about, you have two things going on. You have the causes of or what I call the stressors of what's going to limit life expectancy or make that worse off, and then you have kind of the solution to that, or the access to services that might mitigate some of those factors. And I think the city neighborhoods in Baltimore suffer on both ends of that. So let's talk about the stressors first. So we know, for example, that poverty in general leads to poor healthcare outcomes. So poor neighborhoods are going to be just in general. However, think about things like gun violence, right? How many, if you're in a poor neighborhood in Baltimore, you're 3 times more likely to be a victim of gun violence than if you're not, than the state as a whole, state of Maryland as a whole, right? So that's one thing we have to look at. There are higher rates of drug addiction, of HIV infection, of homelessness. So all of these things together will, of course, lead to more chronic diseases, more chronic conditions. And so there we're talking about things also like diabetes. And again, this is related, as we're talking before, to things like food deserts. It's hard in a lot of neighborhoods for people to have access to healthy food. And it's not just physical access or distance, right? It's also time, right? If people are having to work 2 jobs to make ends meet, to pay their rent, they're not going to have time to go really grocery shopping. And so they're going to opt for a fast food option or something like that. I talked about the built environment, asthma, lead paint, all of those things contributing. So you have a host of interrelated factors that together lead to poor healthcare stressors, more people needing healthcare than in other neighborhoods of the city. And then you look at the other side of that and you talk about access, right? And you started off by saying, we've got hospitals, and we've got some really great hospitals in Baltimore for sure, and we have transportation that can get people to hospitals. So then what's the issue if they need treatment? Well, a hospital is one form of treatment, and having a great trauma center is fantastic if you have an accident or you have a gunshot wound. But after they leave the hospital, what then, right? Who follows up? So there's that part of it. But even more so, people are not going to go to the hospital if they don't have insurance or they're afraid about the cost. And beyond that, what are we doing to prevent people from having to go to the hospital in the first place? So we're talking about primary care. So the one of the agencies of the government that measures shortages of healthcare resources in different neighborhoods is the Health Resources and Services Administration. Mm-hmm. So currently there are 19 neighborhoods in Baltimore that are identified as having a shortage of primary care services. So that could be doctors, nurse practitioners, facilities, right? So that's a huge proportion of the neighborhoods, right? When we're talking about this. You mentioned lack of pharmacies. Pharmacies have closed. Again, people have to go far afield to get medications they might require. And I'll stop there and see if you have any questions, because I have some more stuff, but I want to make sure you get to follow up with what you're interested in.
It's absolutely fascinating. You mentioned, let's zero in on gun violence. Obviously, I mean, it's no secret, deep dark secret, but Baltimore has one of the highest homicide rates per 100,000 of any city in the United States. When I think of that as a potential driver of life expectancy, I'm curious about the true impact of homicide rate driving a disproportionate life expectancy of 18 years. Yes, there is correlation of everything that you just said. There's correlation between low income, poverty stricken zip codes, homicide rates, education. There's significant correlation between lower income inner city zip codes and the decline in life expectancy. But I need to think more about causation. Are these factors causing life expectancy? They're certainly correlated, but I'm not sure that they're causing that. I mean, you just growing up in Baltimore in a poor neighborhood is not a death sentence for you, primarily because what's really curious to me is that, and I did a mapping exercise, everyone who lives in the city of Baltimore is within 2 miles of a level 1 or a level 2 trauma center, a very good hospital. We're talking about hospitals like Johns Hopkins, University of Maryland, Sinai, Bayview. So I don't know if city planners strategically plan this or whether it's just out of pure coincidence, but everyone within the city of Baltimore generally lives within 2 miles of one of those centers. So it's not a capacity issue. This life expectancy is not, I think, related to an undercapacity of health services, except for the one that you just brought up, which is primary care. And that's interesting. I think I need to do a little bit more kind of deep dive in that aspect of it. But it sounds like to me from what you said, it's a perfect storm of a multiplicity of factors that are, when compounded, lead to low life expectancy. Am I thinking about that correctly?
Sure. And, I'm not a quantitative geographer. I'm a qualitative geographer. So I'm trying to get at the kind of deep causes and the story behind all this stuff and tease it out. But there certainly have been quantitative studies that have been done which do show causality between poverty and poor healthcare outcomes. So I think, that's a given. the precise extent, so yeah, gun violence is a contributor to that. I doubt it's the highest driver for sure. I think you're much more likely to look at things like diabetes rates, like those kinds of chronic conditions, hypertension, that people, like, and as you said, you're near a trauma center, but even if you go to the emergency room, because you have to get your insulin shot, who's following up with you to make sure that you get your insulin shot? How do you get those resources? And so primary care, like we said, is one example, but we could name anything: maternal care, we could mental health services, right? They're all underserved in these areas. And remember, service, the way it's defined in shortages in service, doesn't mean just proximity. It means also affordability. It means the correct personnel and the correct services for the region. So one of the things that has been found for some of these solutions, I know we're going to get into solutions later, but for example, mobile health clinics, right, which is a great idea, right? Bring the healthcare services to the people on a mobile basis. But a lot of times it's found that those services, they don't have the capacity to do the stuff that the people actually really want or need in that particular neighborhood. So they're starting to get better about figuring out how to target these services. Internet access. I was looking at the website for a homeless organization that was helping homeless people get healthcare, and they're like, "Oh, phone for an appointment or make an appointment online." Well, if you're homeless, it's really hard sometimes to get internet access or to have a phone. You're assuming a lot of things. So there's so many different ways, and I think the final one I want to mention, because I think it's important, is discrimination. And Baltimore obviously has a long history of segregation and discrimination. And if you look at the city from a racial perspective, you have what's called the butterfly effect, and I'm sure you're familiar with this, Kent, right? Where you have the corridor stretching from the Inner Harbor northward, where it's predominantly white, higher income, and then on the far east and far west, you have African American, lower income, lower outcomes generally. So the question, and those are the same places where you find these shortages. So it's all correlated. And that's from a history of stuff. And it's despite maybe the best efforts of people today to say, well, we're not actively discriminating. We're not trying to segregate anymore. But as a geographer, what you know is that these historical things have staying power over time. And then that also can cause, from a cultural perspective, people to have a lot of distrust of the system. So people might not be taking advantage of these things because of the distrust of the system. So there's a multiplicity of factors involved, which we could do a show on each one probably. But.
No, that's very interesting. So from what I gather in listening, there's to some extent maybe a certain amount of dysfunction in continuity of care. I think we're thinking about healthcare as a society in the wrong way. I think we're trying to drive society solutions down to the local level when we really should be thinking about local solutions driven up to society's level. Because if we continue to look at a health system where people have great access to care, they don't have to deal with redlining issues that you just mentioned. These solutions are not applicable when you drive them down from the higher level down to try to retrofit those into a society or into different zip codes in Baltimore City, as the case may be, that are struggling with different social determinants of health. And that's why I'm trying to highlight and showcase what those determinants of health are so that we can begin to have meaningful conversations about how to address life expectancy and other social determinants of health. I've been looking at these statistics for Baltimore City for 20 years now, and let's be honest, nothing has changed.
Right.
What do you think government's role is, what their commitment should be to healthcare for city residents? And then I'd also like to say, ask you what you mentioned Johns Hopkins. That's a medical oasis in a sea of poverty, and in a sea of zip codes that have that lower life expectancy. What is their commitment, and what should it be towards improving social determinants of healthcare?
Sure, and that again, and I would just say it's a multifaceted problem. So there's a multifaceted solutions that we're going to need for all the reasons you just outlined. And certainly from my background as a geographer working at the community level, right? the best solutions are bottom up. So I'm a firm believer that people know what they need. And so many times these decisions and where to put a facility and how to provide the services and who provides the services are decisions made above the level of the community. And then people are kind of surprised when they're not working, right? Because there was no community buy-in. There was no back and forth with the community. What do you actually need here? You know, is a pharmacy the priority, or is a primary care service center the priority? How much we focus on childcare issues? How much we focus on chronic issues like diabetes? So I'm a firm believer, if you ask the people, they will tell you. But I think we don't often ask. And the solutions, to your point, are going to look different depending where you are. And that is even within the cities, within the neighborhoods of Baltimore, right? You're going to have different neighborhoods having different solutions. What's common among that is, one, the solicitation of the public comment and public input into the process. Two is to have flexibility. And that's not something that is always good when you're talking about government funding or even foundation funding. There's usually a lot of requirements, understandably, about how money is spent to avoid fraud and abuse, but it also can really limit the innovation and experimentation of what could possibly work at the local level. So I think that's part of it. And there are things starting to be done, right? So for example, even in Baltimore, there has been work. I mentioned the mobile clinics. There's actually been work trying to bring together all the providers of mobile clinics to say, are we really doing a good enough job, and how can we do better? And they identified, this is just last year, they identified a series of measures they could take to try to coordinate that care better and provide more for the population, including cancer screening services. You know, how many women in these poor neighborhoods actually have access to a regular mammogram, right?
Who pays for that, Sean? Who pays for mobile integrated services?
So a lot, again, it's a whole host of different players, right? You're going to have the federal government kicking in a lot, again, through that Health Resources Service Administration. You're going to have foundations, nonprofits putting in a lot. You're going to have the city and the state putting in money. So it's all of the above.
Let me ask you, thank you for that. I have an alternative solution. What you described, and rightly so, is a public solution to address social determinants of health. How about a public-private partnership? This show is all about market-based approaches, market-based solutions to addressing new avenues to get to things like social determinants of health. So I think that those solutions have not been proved, they have not been tried. So I'd like to encourage thinking around public-private partnerships. And I think that, to your point, depending on the payer, a physician or a hospital's salary, is certainly in question about what resources are coming into the payer and what they're paying for these types of services. Why don't we twist that around just a little bit to focus on unnecessary health resources utilization? As someone with your background, I'm sure that you can appreciate that poor health outcomes are associated with driving high costs to emergency rooms, to inpatient hospital visits that are, quite frankly, unnecessary and show overutilization of the healthcare system. If we could kind of lasso that and do a better job societally in reducing unnecessary health resources utilization, and then share the savings with the provider network, I think that we can prop up or buttress your comment about the healthcare providers and the healthcare system having to undergo lower levels of resource utilization, lower resourcing in general, by sharing savings associated with unnecessary health resources utilization. I'd like to get your reaction to that.
All solutions to this are going to require public-private partnerships. There's no question. The providers are a big part of that. Hospitals, all of the above. And there are some in very small areas of providers getting into the idea and payers getting into the idea of how do we actually keep people healthy so they're not having to go to the emergency room. You're absolutely right. A trip to the emergency room is so much more costly for payers than a primary care visit to a local doctor. So how do you kind of provide those things and get everyone on board to say, we're all going to save money, by doing this, and there'll be more opportunity for everybody to get the reimbursement they really deserve for the time and the effort and the resources they're putting in, and still have better healthcare outcomes. So absolutely, it's a big thing.
Well, yeah, you said it wasn't your area of expertise. It is certainly my area of expertise and research interest, in aligning financial incentives to promote better healthcare and less wasted health resources utilization. So I'm absolutely passionate about that. I don't think that we can wait for anyone to solve this crisis. It's not going to be Johns Hopkins that solves this crisis. It's not going to be the city government of Baltimore. I think that it needs to be solved by people who are passionate about improving healthcare by creating market-based solutions that bring public-private partnerships together to address these situations. So I know that, I've certainly enjoyed our conversation, Sean, getting to know you, getting to know your background. You have a wonderful, fascinating background. As a geographer, I find that fascinating. And I think that you should be a key player in any public-private partnership that is associated with the end result in mind to increase life expectancy for patients and improve the quality of life care for patients, particularly in Baltimore City. And, I suspect that the same things that are going on in Baltimore City are also happening in Philadelphia, New York, Chicago, Los Angeles. So it's not just a regionally isolated incident for Baltimore, but rather it's just a U.S. healthcare system in general. And I hope we can create these public-private partnerships.
I just wanted to just one caveat to that too is, a lot of times when we talk about public-private partnership, we're talking about a government and a private entity. And again, to my point, involving the people concerned is really important to get those bottom-up solutions. If the solutions are going to work, you need to get the input of the people being served. And I think that's something that's often overlooked and hopefully will be in whatever the next round. And also, you're absolutely right. It's not just Baltimore, it's all cities. And it's not just cities. Rural areas have the same exact problems in different ways, but it's the same exact. It's the poverty, it's the isolation, it's in that case more distance, but also just all these chronic stressors that are leading to this lowering of life expectancy in those areas as well.
Well, I hope, Sean, that we can have future conversations as we zero in on specific areas that we can potentially create these public-private partnerships. I'd love to re-engage with you and get your thoughts on that.
Absolutely. My pleasure. Thanks so much, Kent.
Thank you, Sean. Have a good day.
Thank you for joining Market-Based Approaches to Finding Value in Healthcare, where we looked at social determinants of health in Baltimore. If you'd like to connect with me, feel free to email me at akmckin@comcast.net. Thank you. Have a great day.